Hello, my name is Dave Rakel. I'm at the Yahara Clinic, and I thought I would provide a quick conversation starter on non-alcoholic steatohepatitis, which recently, over the past 4 years, has become the second leading cause of cirrhosis. It surpassed viral hepatitis, not only because now we have good treatment for viral hepatitis, but we're eating a lot more sugar. And so alcohol and sugar are the two main sources of liver failure in America. Let's talk a little bit about the pathophysiology of that. When we eat a bunch of sugar and then don't push it into the muscle with exercise, the body wants to store that sugar. So the cholesterol it makes to store sugar is triglycerides, and that sugar gets stored as fat, and that stimulates the liver to make a lot of triglycerides. So that's the fattiness in the liver. And what's on the differential for pancreatitis? After scorpion bites, what's the next answer from our medical students? Hypertriglyceridemia. So that elevated triglycerides over time destroys the beta cell function and leads to diabetes. These are very similar conditions: prediabetes, metabolic syndrome, fatty liver, PCOS. They all have the same underlying pathophysiology. And if you look at triglycerides as an independent risk factor for atherosclerosis, it matters. As you can see, the higher the triglyceride, the greater atherosclerotic plaque development, independent of LDL. This is one of my favorite predictors of longevity, is to see what people's triglycerides are. Granted, it might be genetic, and many people have a genetic cause, but the majority is lifestyle, from eating too much sugar and not pushing it into our muscle as fat, or as energy, What's the cure for non-alcoholic steatohepatitis? Exercise, nutrition, and maintaining weight loss. 10% of weight loss cures 97% of fatty liver. This is the gold standard of care. How do we encourage and support and sustain these lifestyle choices so we can get rid of the disease instead of just managing it? But if we are going to just manage it, some of these newer drugs, like glucagon-like peptide, will likely have an indication for non-alcoholic steatohepatitis in the near future. As you can see here, this was pretty low dose for obesity. Now semaglutide can be prescribed up to 2.4 milligrams. They did a slow titration in this study, starting at just 0.1, going to 0.2, then to 0.4 on I think a 1 to 2 week basis increments, and significant reduction in body weight, liver enzymes, and percent of resolution. How much does this cost? How much does semaglutide cost? More than $260 per shot. So it's a weekly shot. So that's over $1,000 of medical costs for something that just manages the disease. It may cure it, but it doesn't sustain it. You have to rely on a drug the rest of your life to sustain it, unless you change, or we change, our lifestyle. So this is my favorite inexpensive treatment of hypertriglyceridemia as well as diabetes, is to add some soluble fiber. So what does soluble fiber do? It fills your stomach up with water like a sponge, because it soaks up the water. It's soluble, but it also slows the glycemic index of whatever food you eat. So if you take a teaspoon of soluble fiber like psyllium and put it in a glass of water and drink that up before each meal, that not only slows the absorption of sugar, the speed of absorption, which lowers triglycerides. It also lowers hemoglobin A1C by 0.58, almost 0.6. For the FDA to approve a new drug for diabetes, it needs to reduce the A1C by 0.3. So that's pretty darn good for pennies a day. Our local expert, Dr. Saeed, is in our Department of Internal Medicine in the Gastroenterology Division. He's our local expert on non-alcoholic steatohepatitis, and I asked him how we should manage and follow fibrosis, because just like hepatitis, with chronic inflammation, the liver is susceptible to adenocarcinoma. So we want to prevent that, and we prevent it by doing the things we just talked about. But if it progresses, we can do the FIB-4 score, which is age, AST, ALT, and platelet count in that formula. And then if someone has a persistent score between 1.3 and 2.67, or if someone has an elevated score greater than 2.67, then he recommends that we order a ultrasound elastography, which is an ultrasound or MRI assessment of how fibrotic or stiff the liver is. And so I just cut and paste this diagram. He's on a national guidelines group with the VA to implement this once all the evidence is collected. So how would you treat fatty liver in your clinic? Maybe you have some good ideas that you can share with your partners and your colleagues. How can we treat this pandemic of metabolic syndrome, fatty liver? Just think how many of our patients have this. So instead of just prescribing a bunch of drugs for this, how can we create a lifestyle support process through nutrition and mental health to really help our patients overcome and cure this condition rather than just managing it with a risk of polypharmacy? So that's it. That's all I got. I hope this stimulates some good conversation, and thanks for coming together for the RISE program.